Hi, everybody. I'm here. I've lost my colleagues apparently, so hopefully they'll be joining me soon. So today we're going to talk about the antibody testing, which hopefully will be as seamless as possible as we get started on this. I know you guys have had a lot of questions about it, so I'm hoping today that we can spend some time going over that, just kind of talking about what to expect from the test, how we're going to roll it out, all of those things. So if you guys, can you guys hear me? Please let me know if it's not working out, because I am making sure we got this all set up. So first off, talking about what an antibody test is. So one of the first things to think about when we're doing these antibody tests is what is the accuracy of the test? So when we talk about testing in general, as we talked about before, when you are getting a result, are you actually getting the people who actually have the antibodies? And are you, with the people who have the antibodies, are you finding the people who are don't have them? And are you also getting a negative test for those people that don't have them? So with that, the accuracy is so valuable. And what we've seen out there, we've had so many different tests come along without clarity on how accurate these tests really are. So the big question for us has been, how do we get an accurate test, and how do we make that real for you guys so that we can feel more confident? James is here, thank God. He's going to try to get Shay on board here. So our hope is next week we're going to start on Thursday rolling this out as a pilot with some patients in our practice who are higher risk, who seem to have had COVID based on their symptoms and in the past, and so we're rolling that out for them to start. We're going to be drawing blood samples from the car, so doing a venipuncture. Like, it's not just a finger stick the way that we're doing this. It's a blood test where we draw blood from the vein, and then we'll be collecting that and bringing that to the lab in San Diego. The reason we're rolling this out slowly is we want to make sure with the lab in San Diego that we are getting accurate, like seamless transfer of the samples to them. James is here.
Hi.
We're getting seamless. Oh, there's Shay. Seamless transfer of the samples to them. Shipping down to them is a concern, so we want to make sure we get that right. So we're starting a little bit slow here. We're going to do some samples on Thursdays and roll that out and make sure that works okay. So that's the first thing. And here's Shay, yay. Hi.
Sorry I'm late to the party. Bit of a madhouse over here.
I know, homeschooling is a lot of work.
Yeah. I'm just trying to keep the toddlers alive. I wouldn't call it homeschooling. It's a lot of work. Yeah.
So I started with talking about the importance of accuracy with the antibody testing. And then now I was just kind of talking about logistically how we're going to be rolling this out, how logistically we're going to actually be taking a venous blood sample from people, not a finger stick. Right. And so that's sort of the logistics of it. And then once we have clarity that we're able to get these samples to the lab, that the lab is reporting back to us in the way that they're telling us they're going to report back to us, and we can feel it's a little more seamless, then we'll start rolling this out and doing more frequent testing. But we've been so careful about jumping in too quick and creating maybe mistakes or inaccuracies and things, or jumping on a test too quick that we don't trust. So I hope that all of you guys can understand that, can respect that. That's why things are moving a little slower with how we're rolling this out. So that's the logistics of it. I don't know, do you want to add anything? Either of you with logistics? Any thoughts?
I missed the whole thing, so.
I'm sorry. I know. I feel like I missed it too. I'm sure you said that we're starting with those kind of higher risk populations to start as a trial. And so we'll start scheduling people that don't meet those two criteria, that we had emailed out. We'll start scheduling you all once we get the flow down. of how
Right.
it's going to work with people who have tested positive or have like known exposure in a high risk setting, like healthcare workers.
Right. And I think the other thing to say too, we wanna put this out there for the rest of the community, but we want to start with the patients who have been with us, who are patients in our practice first. So we want to help your friends and family and all of that. You guys have been referring your friends and family for the nasal swabs because we can't roll this out so big and so quick. We want to make sure we're prioritizing our patients who are in our practice right now. So just so you guys kind of keep that in mind when you're thinking about testing and referring people for testing for the antibodies.
And just to reiterate, I'm sure she mentioned it's such a different workflow. As some of you have experienced, the nasal swab is very quick in and out. Blood draws are a little trickier in terms of making sure we do it in a safe way. Some people are a little harder than others to get the blood drawn, and so it just adds up in terms of our ability to collect it as easily. And so yeah, that's the big reason. And as well as working with this lab is a new one that we're want to make sure we do properly.
So yeah, go ahead.
I would just say real quick, the only caveat to what Emily had just said about trying to prioritize patients within our practice, and we're all on the same page with that. The only caveat maybe those of you and there's been more than a few now in our practice who have tested positive. We do want to we think those that you were in close contact with before you tested positive, those in your household, even if they're not members of the family, definitely talk to us about those. Most of those we want to prioritize to be tested, and so that's something we want to talk to you about. And I think those of our patients who have tested positive, we're already having those conversations, but just in case anyone was confused about that, or then let us know.
Great.
Yeah.
Did you talk about the test already, like antibodies and
I
all that stuff?
I fumbled through talking about accuracy of testing, but maybe we can revisit that because now you guys are here, so I'm not anxious about talking.
And we can have lovely disagreements, perhaps not disagreements, but discussions about it, because it's a little confusing. So one of the things we've talked about, and that's been really challenging, is to understand, and we've repeated this so many times, not because we forgot we told you already, but it's incredibly important for us to really keep in mind that these tests are part of the picture, right? And so every bit of information, your history, your symptoms, people you've been around, all of those things are incredibly important for us to decide how to interpret these tests. And as we've said before too, this is such an early phase. We're in this time of uncertainty to try to really figure out the meaning of these tests. And we're making assumptions, and we're being very transparent about what assumptions we are making. But that's really key to understanding the limitations of the test and how the results of these tests can really help us moving forward. In terms of the IgG testing, one of the questions that has come up repeatedly is, does that mean I'm immune? And I don't know, what does that mean to you guys? Let's say I have a positive IgG test, and I never had any symptoms, right? Like over the last, I had a healthy year this year. What would you tell me in terms of I get a positive IgG antibody test?
Do you want to go first? Do you want me to go first?
You go and I'll.
So one of the things, so when I'm thinking about how to respond to people individually about this, I think it comes down to making some assumptions based on our experience with similar illnesses that we have more of an understanding on. And so all of that is couched in so much uncertainty. So it's kind of like we're assuming that it's going to be this way with COVID-19 because it's been this way with other similar types of SARS or MERS viruses in the past. And what that has looked like is that, yes, when you have an IgG antibody to this disease, you are more immune or less likely to get severe disease, and that immunity can persist for some time. And that's very vague, but it could persist for a year or two, or it could be something where it doesn't persist very long. And then if you got reinfection, then you could get something that might be less severe. So these are all possibilities. So is the protective effect meaning that you will not get infection at all, or that you're less likely to get severe infection? That would be my hope, is that that's what this represents. And with our experience with other similar viruses, that could be a reasonable assumption to make. So I think that kind of is where we would go with it. That being said, the real question I have is at what level of IgG can we make that assumption? And so, for example, we were talking last time about measles, and measles is one of these, like, once you have antibodies, in most cases, nothing's ever 100%, then you're immune for life. And so, and we know at which level of antibody you need to have to be immune to measles. So at what level of IgG can we say you're going to have a less of a risk for severe infection, or maybe even better than that, like immune to COVID in the future? We don't know that. We really don't. And so there's a lot of assumptions that have to go into that. Just the existence of one antibody in your blood doesn't, to me, wouldn't be enough to say, okay, well, yeah, you're immune, or you're safer. But then is it like, I don't know these numbers, but is it like if there's 1,000 antibodies in your blood, now you're safer? So that's really the question. And that comes down to the difference between a qualitative test and a quantitative test. So quant means numbers and qual means quality. So a qualitative test just says you have it or you don't. It's like a yes or a no, like a pregnancy test, right? You're either pregnant or you're not. You have antibodies or you don't. And then a quantitative test is a numerical value assigned to how many antibodies you have, right? So unlike pregnancy, you can't be a little bit pregnant, like you're pregnant or you're not. This is like, there can be a little bit of antibodies, which may not be as protective as a lot of antibodies. And so getting a quantitative value or a number of antibodies is really important. Well, I say that. I believe that it's important because it will give us more value in the future as we start to understand what these levels mean. Am I talking too much? Does that make sense?
Yeah, no, I can piggyback on that. I think all of that is really important. That is definitely one huge question that we still have, still being so early in our knowledge of this disease, is how exactly does immunity work? Exactly what Emily was talking about, what level of antibodies is actually protective, and then how long does it last? Because that varies, among different diseases. We know that immunity to certain types of coronavirus seems to last, sometimes less than a year, and others, and the other novel coronaviruses, MERS and SARS, which Emily talked about, it seems like immunity, once you have detectable antibody in your blood, then it lasts a couple years. So how long does the immunity last? At what level of antibodies is it actually protective? So that whole area is something we're still learning about, and studies are being done, and we're in the process of figuring that out, but we don't have a ton of clarity yet. So that's, one consideration I would want to explain to someone who had a positive antibody test. And then even the other thing I was thinking about when James posed that initial question of, so I tested, I'm in this situation where I don't necessarily have a high risk of exposure, and don't have recent travel, haven't been around anyone that's sick, I've been isolating, I haven't had symptoms, but I'm just, I'm dying to know, and I got this test, and then my antibody test is positive, so then what do we do with that? So there's all those considerations that Emily just talked about of not being totally clear on what immunity means, but then also even farther back than that, the other consideration is, how good of a test is this? And the answer to that is based on more than just, the stats on specificity and sensitivity, which mean how likely is it that if you test negative, you truly don't have the antibodies in your serum, in your bloodstream, or if you test positive, you truly do have the antibodies in your serum. So, so that's one measurement of how good a test is. But to come up with those numbers, specificity and sensitivity, it's more than just the technical aspects of how good the test is. It's also based on positive predictive value. So what is your risk of, should you have been someone that was tested in the first place? What is your risk of having the test? So that positive predictive value also heavily depends on the prevalence in the population. Positive predictive value really increases if 50% of our population has now been exposed to coronavirus. Well, we don't think it's that high, but we really don't have a good sense of how high it is. I mean, we rolled out testing pretty late. The criteria in most of the big, medical systems for being tested are still pretty tight. Most people have not been tested. We're really guessing and projecting at what the prevalence is in the society. So that affects our positive predictive value of doing a test. So all of those things, again, just make it difficult for us to clearly say that if you tested positive, you definitely were exposed to coronavirus at some point, and these antibodies are coronavirus antibodies that we're finding on the test. The test is just in early phases of development. I don't think that means there's no utility at all to this test, but it's just, again, it's just so important to understand that we're in early phases. If we need to be thoughtful about how we're administering the test. Any type of blood test, imaging test, any test that we do, we always want to make sure we're doing it. The test is going to be a much better test if we're doing it for the right reasons. If we have some clinical, good reason to think that you should have developed coronavirus antibodies or that your test would be positive. So yeah, sorry if that was a little jumbled, but
And so to actually piggyback on that, so now I'm going to ask the same question, except this time I'm going to say, in March, it was weird. I had this, couple of days, I had a fever. I lost my sense of smell for a day. And I felt pretty good after that. And, now I have this IgG test that I just had today. What do you guys think of that? Like, what does that mean to you?
Well, it's partly too what James was telling me about earlier is this idea that all these people that were supposedly asymptomatic, maybe they didn't, if you really dig down and talk to those people, they had some minor symptoms that actually could correlate. So like those kinds of minor symptoms that would, loss of sense of smell is a more specific thing with COVID. So that would make me say, well, maybe that is something that seems quite realistic. Whereas like completely asymptomatic, no risk at all, and then a positive IgG, I would wonder, is it a false positive or not? Because again, like Shay was saying too, we still, there's so much we don't understand. So although we're trying to use positive predictive value and prevalence, like Shay was saying, we haven't done that many tests. And then every time, like we've done this with you guys with our live streams, we'll be like, well, yeah, it's, your dog's fine. And then all of a sudden it's like, wow, now your dog can get it. So there's so much to be learned from this. So it's possible that we will find more information and tell you guys a different story next time. But I think that's partly why we're trying to be as scientific as we can. And with the information we have. And so it sometimes looks like a little bit of back and forth, but it's just, we're trying to be thoughtful about it. So anyway, I'll let Shay answer your question.
Yeah.
Too.
Oh, no, I feel like you answered the question, but that made me think. I wanted to throw in there because we keep saying there's so much we don't know. There's so much we don't know. I was just reading this morning as I was reading over this. There's there's many studies being done, but there's a large NIH study that's taking participants that think that they may have had symptoms since January, but have never been tested, that might want to get an antibody test. So you're ineligible for this NIH study if you ever had a COVID viral test. But if you have not, but you think you might have had symptoms, we can maybe send out the link.
Yeah, we should send a link. It's an NIH study. Yeah, there's 10,000 participants, I believe, that they're recruiting, and there's actually some other studies from Stanford partnering with UCLA as well as USC that started this past week on antibody testing. And as you can tell, if we have these large organizations, starting testing, we're in the same boat. So that's why, once again, going back to this, we're in the same boat as learning about how to interpret these tests in the clinical picture for people who may have had symptoms, who may have not, and what that means. So yeah, we can forward that at some point.
Our hope is, and we want to roll this test out and make it available to you guys because we do feel there's value in this knowledge, and having the knowledge as things unfold more and more. What does the test mean? I think we're going to get more, I hope we're going to get more information soon. Like they're saying, these studies are coming out. So we can get you guys tested and get your results to you, and then you can have that. And as time goes by, we can learn more and more about what that means.
Right, and I think what you mentioned as getting more knowledge, it's actually, to me, the opposite. I think we're in the information gathering stage. And the more information we can get, the more we can create patterns and understand the patterns, and then get the knowledge from the information. So we have a little bit of information already, but the more information we can get, the more knowledge we can glean from all of this, working together with other research institutions and all that.
Yeah.
Okay, that makes sense.
Yep. Yeah. So one of the questions, we've had some questions about turnaround time. How quickly will the labs come back from this lab in San Diego? They have told us it's 2 to 3 days? Or?
No, so it's 24-hour turnaround time once they receive the specimen. So I don't know if Emily told.
Once they receive it.
Yeah. So I'm the courier this Thursday. So it's. Yeah, so I'm going to be driving the specimens down to San Diego once we collect it. They have to be refrigerated, and there's shipping involved. And once again, this is why we're not rolling this wide stream yet. I'm going to be driving it down so I can check out the facility, as well as actually, making sure the samples are hand delivered. And then once we can figure out the shipping logistics, then maybe we can continue on a wider rollout with them. But it's a 24-hour turnaround time once they receive the specimen. So we'll see how that goes. So this Thursday, we should hopefully hear something by Friday afternoon, maybe Saturday morning. So once again, this is our first run at it.
And we're hoping to maybe next week in our live stream, from one of the reports we get back, we can show you guys what a sample report looks like and kind of review that with you on the live stream, so you can see what they're telling us and all of that. And we're not married to this lab. We have no financial interest in this. Like you guys, that's why we're here for you guys. You guys are giving us like the ability to have no conflict of interest for you. So we're not getting paid by this lab. We're not collecting money from anybody for these tests. So we're doing this for you guys. And so we're looking out for other labs too. If you know anyone who locally has a real test, and that's the question too. There's so much fraudulent testing out there that learning how to sort through that is a challenge. James was just talking with a group of doctors this morning about how can we educate people to sort through the fraudulent ones and the real ones. And so, this lab we feel more confident in. That being said, it's possible that we may find that we work with a different lab, or that, we're still looking around and vetting this as much as we can. We just want to have things available to our patients as in a accurate and timely way.
It's a work in progress, and I'll repeat what Emily said. I mean, this is we're trying to do what's benefiting all of us. So, we're just going to keep moving forward and see where it goes.
Yeah.
One of the other questions regarding, I think we answered this already. Does being positive for the antibody give a person immunity or partial immunity? We kind of answered that, but you want to specifically mention that one question?
Maybe
is a good one. And Shay was alluding to, there's been some studies on with SARS and MERS back in the day, very small studies already. And I think you can correct me if I'm wrong. I think MERS, they said they had like 3 year, they saw some antibodies persist for 3 years, but even then the antibodies weren't as effective necessarily at the end of that 3 year period. SARS, I think, was a little bit shorter. Some of the the old coronavirus, once again, very small studies with literally, I think, 10 to 20 patients showed that the antibodies lasted in their bloodstream, less than a year. So once again, we don't have clarity of specifically what this one, is it going to provide immunity versus partial immunity before a vaccine? We just don't know at this point in time. But there's possibly some form of immunity, at least, is a guess.
And you think about coronavirus, which is the common cold, like we get colds over and over and over again. So it's kind of interesting in that way. And it's not like, it's not as severe or scary as this. So could that mean that COVID starts to look like a cold for you if you have antibodies? So.
And the same note, the other question is, there's some reports and case studies of people being reinfected with potential COVID. I think reports in China specifically. And it kind of goes potentially back to that similar answer, which it's really unclear as to, the incidence of that, the percentage-wise. Are these just rare cases? Is there something more to be said about that? I don't know if you guys have any answers, but I have an I don't know answer to that one.
It's tricky with those ones. Is that because the initial test, the initial viral antigen test that tested positive wasn't actually a true positive, and so it's not a reinfection, it's
right.
Getting infected all over again, being in the early stages of tests, it's hard to say. Was it is this really reinfection? Is this us still just honing our tests and using them appropriately? So hard to say. It's been a really small number, it seems like, so far, of reinfection rates, but it's also a very new disease. So
right. Go ahead.
Another question was, it's kind of similar to the scenario I proposed earlier, but having friends, family, patients saying they were sick earlier in the year with a fever, flu-like kind of symptoms. Is it possible that was COVID? That's another question.
Yeah.
That people are
I mean, I feel like I would want to know if I were them. And so I would want this test, which is, part of the reason it's like we kept going around, well, we can't really do anything actionable. It's not like we're going to say, okay, your IgG is high, you're good. Like, go into the nursing homes and go work with just don't even, we're never going to say that, because that would be completely reckless. So however, there is some this, you want to just have some information about this whole thing. So I would want to know if I have this, my mom was sick a few months ago. And so I want to test her and see, is she protected? And does that mean I'm going to go over and have my kids climb all over her? No, absolutely not. Like, that's not the point of this. It's really tempting because I want so badly for someone to help us with our children right now. But that being said, it's not, I don't feel like that's safe or prudent. So.
Mm-hmm. But it is, but I agree, but there's this balance. But it would be helpful to know that. I think we're all in the position where those cases, those patients of ours who are wondering and who had those bad colds, and, let's go ahead and do the test. But again, just with this understanding of we can't use this to make major changes in the way that we're social distancing right now. We might get to that point where more clarity comes about these tests, but right now it's kind of going to be to help us gather data, to help us get to the point where we're understanding, better how to interpret these tests, but we're not going to make major recommendations based on it. But we still think it's useful to do the test. So that's where we're at.
Yeah. Here's a good question. Jan, thanks for this good question. He's asking, like, MRSA, one may be considered a carrier for life. However, one can spread it to others. If we have antibodies, can we be a silent carrier, and should we all social distance? So, it's a very interesting thing, this idea of being colonized or being a carrier of a bacteria. And so, like, for example, some people will always have strep in their oropharynx. So anytime they come in, even if they don't have a sore throat, if we swab them, they're going to come up with a positive strep test. And we don't advise those people not to share drink. Well, I mean, in general, you got to be thoughtful about sanitary things, but we don't give them more strict precautions than general safety measures or health measures. So I think if you're the idea is that if you have strep and you're having symptoms, you're having a sore throat, you're having a fever, that now it's become more virulent, more aggressive, and more likely to spread. And so in those scenarios, you actually need to be more distant from people. So I can speak about that very clearly with strep. Can you make this inference into COVID with that parallel? I don't know. I don't know if that's something that we can do. But someone being colonized or having antibodies is not the same as having, in general, with diseases, is not the same as having symptoms of coughing and a positive PCR. As far as infectivity goes, in general, that's not the case. Is that fair?
Yeah, generally it's copies of the virus. It's antigen. It's the actual virus that, that's what, which is what we have been testing for with the nasopharyngeal swab.
Right.
That causes transmission of the virus, not antibody. Generally, antibodies are not infectious. So, that should be, we're still planning to do, is this correct, guys, that we're still planning to do a nasopharyngeal swab with antibody testing?
It's a really good question. We were kind of going back and forth a little. Like if someone had a positive COVID.
It made more sense to me with the finger stick, but
right.
with this blood test, I don't know. Yeah.
Right. Yeah. I feel like when James and I talked about it and we didn't get a chance to talk, it seems like we should do that on a case-by-case basis. If people are, I mean, at the same time, if people are acutely symptomatic or just recently having symptoms, does it even make sense to do the antibody right away? Like at that point, you would want to do the nasal swab.
Yeah.
So it's something we can talk about more.
We decided case-by-case basis. We'll discuss with each of you individually if there's a need for repeat nasal swab if you've already had one done.
And if you want to do one, we'll stick a Q-tip up your nose.
It's not just up; it's like way up.
Because where I was going with that is what really gives us information about infectivity. If you're concerned about transmitting it, if you don't have enough copies of the virus that nasopharyngeal swab comes up positive, then you shouldn't be contagious. You shouldn't be spreading the virus.
Yeah, makes sense. The other thing I wanted to bring up was that point of care test, because last time we talked a lot about the 15-minute finger stick test, and I think maybe like 2 hours after we finished that live stream, we got a notice that the actual categorization of this test was it could only be run in a certified laboratory, which we are not. And so there are providers out there who are kind of saying, well, I'm going to do it anyway. But we decided that with that regulation and with already our skepticism about the value of the test and the complexity of now we're giving you a finger stick and a blood draw, it just seemed like we should just scrap it. And then there was weirdness about billing with it. So we just decided to scrap it completely for so many reasons. That being said, if any of you have specific questions about it, or when that becomes more vetted, if that's something that we can administer from our office and feel good and confident about, we are looking for it. I mean, it's amazingly valuable to give you guys results in 15 minutes. It's just they have to be accurate results, and we have to make sure we're meeting the standards of the regulations and that we're following the rules, because it's really important to us that we are doing that and that we're doing high quality things for you guys. So
yeah, it's a wild west right now of testing, and we want to just, we're taking a particular approach and being a little more conservative in terms of what we're offering to make sure we understand clearly where the lines are drawn, and if we're going to overstep them, what that means. And so for the point of care testing, there's actually only one serology point of care testing that's authorized by the FDA under the Emergency Use Act. And so that one is, who knows how to get that one? It's by Celex. But outside of that, none of the point of care serology tests are authorized by the FDA. The ones that are being used for these studies, I'm sure they have some type of design parameter that allows them to use that. We're not at that phase, so nor do we want to take on that responsibility at this point in time. But I have a feeling these point of care serology tests are going to be widely available fairly shortly. We are being patient about it. And once again, it doesn't acutely change our current situation if we deploy it this week versus a month from now. So that's why we decided to do it that way.
Yeah.
And I think just for clarification, we keep kind of mentioning that, we're being careful and we're waiting until things are, we know enough to do testing, but we still are pretty early to be antibody testing. I mean, just relatively, like, the big hospital system, definitely UCI is not anywhere close to rolling out an antibody test. So we're still in the wild west.
We're still in the wild west, yes. Yeah.
I'm glad we're doing it, but I definitely wouldn't say we're behind the 8 ball.
Right. Yeah, exactly. And so that's why we're having these conversations with everybody. That's why it's important for everybody to be on the same page. And once again, on a case by case, we can answer your questions a lot more thoroughly. But yes. Yeah. There's some questions here. One is a question concerned that taking PPE from places that need the equipment to combat the virus directly. So for us, the PPE is fairly straightforward. We are not running through much PPE. This is a relatively a low risk situation for us in terms of exposure. We are not in a hospital setting. So our use of PPE has been fairly minimal, actually, unless you guys have any.
I'm not sure I totally understand. Like,
are we burning through PPE doing these
like
tests?
in our office
Yeah.
when we're doing this test.
Yeah.
Oh, I see. Yeah. No, I don't think that's. I mean, what we're doing is we're wearing one mask, we're changing gloves, and washing our hands between each test.
I think it really helps that we're doing it outside. That also just really decreases risk. We don't need to change gowns, or mask every time, and that's safe to do because they're not being touched. We're just, washing our hands and changing gloves, and so that helps.
Yeah, I guess what we're using needles and we're using blood tubes, but those aren't in any sort of risk of low supply. So I don't know if you, Susan, if you want to say anything else about that. I'm not sure if that was your concern or not.
We don't have, and we're not burning through N95 masks for every single swab. We're using the same N95, and for us, it's actually a relatively low risk procedure. Given once again, it's outdoors. It's a really quick test. We're not spending a lot of time with you, so we feel comfortable with that workflow.
Yeah. Someone asked about chest X-rays revealing COVID. My understanding is that you can see it on X-ray, but more CT. But that would be you have a really active lung disease, not minimally symptomatic, right?
Yeah, I don't know that there are characteristic findings that are specific to COVID. I mean, I think if you're at, if you're at the level where you're hospitalized for COVID, they're following, serial imaging to see how, respiratory wise, how you're doing. But it could look a lot like, another type of, respiratory distress or like a viral pneumonia. I don't think it can be diagnosed on imaging alone. Is that what the question was? Or
kind of, yeah. I think for chest X-rays specifically, it's not something that, there's no one pattern that you would see on a chest X-ray and be like, oh yeah, that's COVID.
Right, that's what I mean.
And similar with CT scans, they had been using it at some point in China to make it a diagnostic. But it's also, once again, in the clinical pattern of somebody who has low oxygen levels, clearly is in respiratory distress, and the situation sounds like really bad viral pneumonia. You put the pieces together, it's likely COVID, right? So, but yeah, not on a chest X-ray.
Let's see. I don't know. Any other questions? This might be a shorter live stream today because we really just wanted to make sure we were covering people's questions about the antibody testing. Like I said, logistically speaking, this Thursday, we're going to do a handful of tests. We're going to try to decide how we want to do it. We want to daily testing. Is it still going to be once a week? If we have to drive down to San Diego every time we draw the blood, we're going to make it once a week. If we can figure out a courier service that we trust and makes sense, then maybe we can start doing daily testing. I'm just trying to figure out the ringing. So any other questions from you guys out there? Anything else you want to say, Shay?
No, I just mainly had the antibody testing.
Okay.
Nothing big.
So we can't
Hang
see
in there, everyone.
Yeah, awesome. All right. I think anything else you want to say, James?
No, that's it. So
No more questions?
We'll keep in touch, everybody, and stay safe out there. Oh, wait, there's another question.
One more question. Which of your tests result sample will get to see next week? We'll de-identify one of the reports and we'll
or maybe I'll show mine.
Yeah, are we gonna do yours? Yeah, we'll de-identify it and put one up for you guys next week. So I don't know if that answers your question. Anything else? That's it.
Thank you. For next week. We'll be back.
Yeah.
Hi, everybody.
Bye. Good week.
Hi, Shay.
Hi, guys. Sorry. Took that away from me. I was like doing so well.